welcome to this webinar. So today we will speak about monitoring leaks. This is the case of Mrs. N. She is 38 years old. She has a myopathy and she's using an oronasal mask. So if we look at the trend over 1 month, we can see airway pressure, leaks, and usage. So as you can see, she's using the NIV every day for an average of 11 hours. If we look at the airway pressure, they are stable. And if we look at the leaks, they are between 30 and 38 liters per minute. Now we can review also the statistics of the leaks. So for each session, you have a number between 34 and 38. And we can review the pattern of the leak over the last night. This is all the night with an expiratory leak around 30 and inspiratory leak around 70 liters per minute. So the question is how to interpret all this number and how to assess the leak in a patient using NIV. So this is what we are going to talk about, and we will see how are the statistics calculated, how to interpret the trends, and how to interpret the waveform. First of all, we have to remember that on Breas ventilator, the ventilator calculates and presents the total leaks. So the total leaks is the sum of intentional leaks, the leak that we like, and unintentional leaks, the leak that we don't like. Regarding intentional leak, this is the leak through the small hole of the mask, and as you know, every mask is different, so intentional leaks depends on the mask. And when you open the bag of a new mask, there is a small booklet, and in the booklet you can see what is the pressure flow profile of the mask. So I will take as an example the mask F20, you know, the oronasal mask with a magnet. And what does it say? Here the x-axis is pressure, the y-axis is flow. And it says that for each level of pressure there is a different intentional leak. So as an example, if you put 8 of pressure in this mask, the intentional leaks is around 35 liters per minute. And if you use 20, it's 54 liters per minute. So if we take as an example a patient that is ventilated between 8 of EPAP and 20 of IPAP, you see that the intentional leak is between 35 and 54 liters per minute. So it's a very big leak, but remember that this is the value of non-invasive ventilation with leak, because the same patient at the end of expiration received 35 liters per minute, which is quite a high flow, and before triggering the breath already gets some air, and this makes the NIV very comfortable. Now, regarding unintentional leak, this is the primary issue in NIV. It's a major cause of complaints and discomfort from the patient. It's probably the leading cause of ineffective ventilation. So unintentional leak impact comfort, adherence, synchrony, sleep, and monitoring. And it's related to the interface, of course, but not only. It's related to ventilator settings and patient education. The way the patient positions the mask, of course, will impact the unintentional leak. So leak monitoring is essential for improving the leak quality, the NIV quality. So first, how is the leak calculated? So this is the ventilator, this is the circuit, and this is the mask on the patient. As you know, there is no sensor in the mask. There is no measurement directly proximal to the patient. So all the measurements are performed on the ventilator side, and precisely the ventilator measures what we call the total flow. The total flow is the flow that exits the ventilator and go in the circuit. And from this measurement, the ventilator will calculate the patient flow and the total leak. So the monitoring that we look at is not directly measured, it's calculated from the measurement on the ventilator side. Because of course the total flow, the flow that goes in the circuit, will split in two: the patient flow, what the patient is taking, and the leak, which is expressed in terms of flow. So how the ventilator goes from the total flow, the measurement, to the leak and the patient flow? Well, Breas Ventilator is the only manufacturer that display the total flow. So the total flow in the monitoring is the yellow curve, while the patient flow is the blue curve, and the total leak is the burgundy curve. So how does it work? First of all, let's look at the total flow, so the yellow curve. As you can see, the total flow is always positive, meaning that the baseline is here, meaning that there is continuously a flow going from the ventilator to the patient. Also, during the expiratory time, it's how the ventilator maintains the EPAP and make sure that there is no rebreathing of the CO2. Well, what the ventilator is doing is that the ventilator will measure the end expiratory total leak. So we'll measure the total flow at the end of expiration. And it's called the end expiratory total leak. Why? Because the ventilator assume that at the end of expiration, the patient is doing nothing. That the only moment of the breath cycle where the patient is not inhaling, not exhaling, so the patient is totally passive, meaning that all the flow that comes from the ventilator goes to the leak. And from this end expiratory total leak, the ventilator will calculate the resistance of the leak, which is the pressure at this time, which is EPAP, divided by the end expiratory total leak. And by this, the ventilator calculates the resistance of the leak. And then, from the resistance of the leak, the ventilator is able to calculate at any time of the breath cycle the total leaks. How does it do it? The total leaks is equal to the pressure at any point of the breath cycle divided by the resistance of the leak. And this is how we get this burgundy curve, which is the total leak, meaning intentional and unintentional, at every point of the breath. And then, from there, the ventilator is able to calculate the patient flow being the total flow, the yellow curve, minus the total leak, the burgundy curve. When the ventilator have the total leak, the ventilator makes an average of this leak, and this is called average total leak. And this is what the ventilator display on the monitoring. For each session, the ventilator display the average total leaks. How to interpret the average total leaks? Honestly, it's very difficult because we have to take into account the pressure, EPAP and IPAP, the TI and TE, and the amount of intentional leaks. So it's very difficult to say if we have a single number, 34, if it is normal or if there is a lot of unintentional leaks. But one way to solve this issue is to look at the trends of the leaks. So here you have one number for every day, okay? And as you can see, well, the leaks are quite stable along the night and the pressure is very stable. So this suggests that there is not a lot of unintentional leaks. While in this case, in the lower panel, you see two things. You see that the average leaks is changing from one day to another, meaning that there are some days where the leaks are higher, so it could be only unintentional leaks. And you see that also the inspiratory pressure is changing. And because we use a pressure support mode, the inspiratory pressure is not supposed to change. So this means that when there is a very large leak, the leak is so high that the ventilator is not able to maintain IPAP. And so this is why you see a decrease in IPAP. So this suggests that there is a very large unintentional leaks in this patient. And then you can see the pattern of the leak. So you can display the pattern of the leak over one night. And usually when we do this, we always display also the pressure waveform. We will see why just after. So how to interpret this pattern of the leak? First of all, you want to know if there is an unintentional leak at the beginning. So to do this, you have to consider the settings. So in this case, EPAP is 7, IPAP is 23 centimeters of water. And then you have to consider the intentional leaks. So in this case, you say it's an oronasal mask. And you will see on the intentional leak what is supposed to be the leak at expiration. For 7, it should be just below 30 liters per minute, which is exactly what the ventilator calculates. And for 23, it should be just below 60, which is exactly what we get. So from this, you can say this patient does not have a lot of unintentional leaks or does not have any unintentional leaks. Now look at this case. This is a gentleman, 38 years old, with a myopathy using an oronasal mask. The settings are 7 of EPAP, 21 of IPAP. And here you see that the leaks looks quite stable along the night, but the numbers are quite high. So again, let's see with the intentional leak profile with 7 of EPAP, we should have something like 30 liters per minute. And here we see that it's more around 60. So it means that during expiratory there is 30 liters of unintentional leaks. And regarding IPAP, IPAP is 21, so we should have something like 55 liters per minute, something like this, and we read 110 or 115. So obviously there is a large continuous unintentional leaks in this patient. And so we have to look what could be the cause of a continuous unintentional leaks. It could be that the mask cushion is torn, or it could be that there is a leak on the circuit, or that the O2 connector is not connected to O2 and has a continuous leak. So this is something we have to look for. Now look at this case. It's a woman with 36 years old having a myopathy using also an oronasal mask. The EPAP is 4, the IPAP is 14 centimeters of water. So if you look at the leak at the beginning of the night, it looks correct, meaning that there is no unintentional leak. But what you see is that some leak appear during the night, okay? And you see that it's a very large leak, meaning that the expiatory leak increased from around 20 to 40 liters per minute and even more at some point, okay? And in the second part of the night, the unintentional leak is so high that the ventilator is not able to maintain IPAP, and you see that the IPAP decreases. This is a problem when we have very large leak that the ventilator cannot compensate, and so the patient is not getting the IPAP that we set. So what can cause this kind of leak? The fact that there is no leak at the beginning of the night means that the mask fits well and that the patient positioned the mask correctly. But this is a leak that appears when the patient falls asleep, so it could be that the mask cushion is worn, or it could be that there is muscle relaxation, meaning that when we fall asleep, there is a relaxation of the muscle and some leak may appear. So we have to reconsider the mask, change a mask if the mask is worn, or maybe consider another type of mask if it's muscle relaxation. Another case of intermittent leak. This is a patient, a lady, 76 years old with a COPD using oronasal mask. She has 6 of EPAP and 26 of IPAP. And again, in this case, the leak at the beginning of the night is normal, so there is no unintentional leak. But we see that the leak appears during the night. It's also intermittent leak, but different shape as before, because in this case, you see that the leak appears very suddenly and stop very suddenly. So when we see this kind of pattern, it's probably positional leaks, that the patient is moving in the night from one side to the other, and when the patient moves, the mask may leak a lot, and then the patient fix it and move again, and so on. And as you can see, again, this leak is very large, meaning that the IPAP is not maintained at the settings. Another case of pattern is this gentleman, 72 years old, with obesity hypertension syndrome, using oronasal mask. The EPAP is 6, the IPAP is 16, and you see that overall there is no unintentional leaks. But what is strange is that we have a lot of small spikes of leaks along the night. It doesn't look so terrible, but it's still noticeable that there is these spikes of leaks. So what could it be? When we see these spikes of leaks, we have to check if there is upper airway obstruction. So short recurrent leaks suggest upper airway obstructions. And so if we zoom in and use a 5-minute time scale, here you have airway pressure, patient flow and leaks, and you see obviously on the patient flow that there are repeated upper airway obstruction, and when there are upper airway obstruction, we may have large spikes of leaks that could occur during the awakening or during the obstruction. And so these leaks are not important, but suggest the respiratory event, which is the problem. This is another case where the patient is using a pressure control ventilation with a target tidal volume. So, for example, the target volume is set at 600 milliliters, and the minimum IPAP is 15, the maximum IPAP is 25 centimeters of water. And this is why you will see that the IPAP is changing, while the EPAP is fixed at 10 centimeters of water. And of course, because the IPAP is changing, you will see that the inspiratory leak may change. Here, this is a typical example. When the IPAP is increasing, the inspiratory leak is increasing. This is expected. So how to monitor this patient? In this case, we have to look at the expiratory leak. When the expiratory leak increases, it means it's an unintentional leak, and you cannot rely on the inspiratory. So here, obviously, there is an unintentional leak. Another case where now the patient is using an automatic EPAP. So in this case, the patient is using a minimum EPAP of 4 centimeters of water and a maximum EPAP of 8, and the pressure support is fixed at 9 centimeters of water. This is a 62 years old with obesity hypoventilation syndrome using an oronasal mask. And because the EPAP is changing along the night, in this case, you will see that the expiratory leak change accordingly. So in this case, you will not interpret the expiratory leak to check if there is an unintentional leak, but you will check the inspiratory leak. When the inspiratory leak increases, it means that there is unintentional leaks. Let's move to patient with nasal mask. This is a lady, 33 years old, with a spinal muscular atrophy using a nasal mask. And here you see the leak pattern along the night. The EPAP is 4, the IPAP is 20, and you see that at the beginning of the night there is no unintentional leaks. But what you can see is that at some point there is a large and rapid increase in the leak that lasts a long time. So typically patients with nasal mask may have some mouth leaks, open the mouth during sleep, and mouth leaks are typically like this. It's a rapid increase in unintentional leaks and rapid decrease in the leaks, because either the mouth is open and there is a large leak, or the mouth is closed and there is no leaks. Now, the question is, what is the mechanism of the mouth opening during the sleep? Well, if you look at the duration of the mouth opening, you can distinguish the mechanism. Here, the duration is long, so it suggests that it is a muscle relaxation. So when this lady falls asleep, the mouth is opening and remains open for a long duration. If we zoom in the same curve to see the mouth opening, this is a 25 minutes time scale, where you will see that mouth opening is a progressive increase of the leak that lasts a long time. Here, for example, around 20 minutes. So this is typical of muscle relaxation. While in this patient, this is a gentleman with myopathy using also a nasal mask. The EPAP is 6, the IPAP is 21. Again, same thing, at the beginning of the night, there is no unintentional leak, but rapidly when the patient falls asleep, we see that there is large leak, large increase in the leak that correspond also to mouth opening. But here you can see that it's a different shape as before. It's a very short mouth opening, meaning that the patient is opening the mouth, closing the mouth, opening the mouth, closing the mouth all along the night. And this suggests upper airway obstruction as a mechanism of the mouth opening. So if we zoom in, and now we zoom in with a time scale of 5 minutes, you will see obviously that there is some upper airway obstruction. So for example here, this is a normal waveform for the flow, and there is normal leaks, no intentional leaks. Here you see that the flow decreases, suggesting upper airway obstruction, and as a consequence, the patient opened the mouth, and this is why you will see that there is an increase of the leaks with very high positive flow, because the air on the back upright goes to the leak, and there is no expiratory flow because it's only leaks. And then the patient wakes up, close the mouth, and recover normal breath. So when you see a rapid increase of the leaks for a short duration, this suggests as a mechanism upper airway obstruction, and you see that upper airway obstruction, it's not one event, it's a cluster of events, which is also a good indication. What is the limitation of this calculation? The main limitation of this method is that the ventilator assumes that there is a constant leak resistance, that the resistance that are measured at the end of expiration is constant through the breath cycle, which is of course not true, because you know very well that most of the time the leak is due to the pressure, meaning that there is a leak during inspiratory time because of high pressure in the mask, but not necessarily during expiratory time because the pressure is lower. So this method of calculation underestimates what we call asymmetric inspiratory leaks, so the leaks that occurs only during the inspiratory time due to the pressure. So how to realize that there are some asymmetric inspiratory leaks? To do this, you can display the flow waveform with a very zoom scale. So for example, 1 minute. And here you will see that there is a small plateau at the end of inspiration, which means that the air goes to the leak. And because of this shape, the ventilator does not reach the cycling criteria, and it will prolong the inspiratory breath, and this is uncomfortable. And this is why we have to set a TI max, so that in case of asymmetric inspiratory leaks, the TI is not too long and it's not too uncomfortable. So this small plateau suggests that there is an asymmetric inspiratory leaks, which is not a big deal in terms of quality of ventilation, but it's more in terms of comfort of the patient. So to conclude, Bruyas ventilator provide calculated total leaks. The single leak value is difficult to interpret, but the trends are very informative. Leaks waveform is essential to understand the leaks mechanism, and be careful, asymmetric inspiratory leaks are underestimated by this method, but looking at the waveform, you can realize it. I thank you for your attention.